So again, thank you for joining us today. My name is, as I told you, my name is Sara Cedillo Jaini. And today we're going to cover a subject, which I think probably for everyone, it's kind of a brain wrecking when you're trying to do a good ultrasound. So I'm going to try and give you some tips to do that. So let's get started. Okay, so there are two ways to perform an ultrasound, or two ways to position the animal when you're performing an ultrasound. The first way is laying on their side. This is something that we do in Italy, and I have seen it do it in other European countries. I have to say that obviously I haven't worked all over the world, so I don't know how you do all in every country. But I have to say that, for example, in the States where I worked, they didn't do it on their side. And I'm going to talk to you a little bit about why do I do it on their side. So what are the pros of doing it on their side? Well, first of all, it's a very natural position. So dogs are more likely to last longer because they're comfortable. Second of all, there's only going to be one person needed to hold them. This obviously is most of the times, because obviously we're going to have very large dogs, or we're going to have very nervous dogs and owners that they're not going to be able to hold them. So sometimes we need 2, even 3 people to hold it. But I have to say, most of the times, just with the owner or just with the other veterinarian, you're going to be able to do it. And then the last thing is, you don't need any extra positioners. This is something that is very important for us who do freelance, and we have to move all over the place, because that way we don't have to carry it with us. So what are the cons? I don't see many. Actually, I don't see any. So that's why I choose to do this. The other way, obviously, is laying on their back. And this is what I've seen in most of the other countries. I have to say, the pros are going to be that the animals stay okay. Cons are going to be the opposite of doing it on their side. So when you start to do an ultrasound, you have to be organized. You have to follow an order. It doesn't matter what kind of order you want to do. What it matters is that you always do the same order and that you follow it. So when you're organized, you're going to do a faster exam. You're going to do a more complete exam, because it's hard to forget it. I'm going to explain why now. And then you're going to do a better report. So if you always follow the same order, you're going to know what is coming next. So you know that after, for example, let's say after the spleen, you're going to do the liver, or you're going to do the stomach. That way, if you always follow the same order, you're not going to forget to do all the organs. So sometimes you're doing the ultrasound and you're thinking, did I already take a look at the testicles? Did I already do the spleen? So if you follow the same order, you're not going to have that problem. And also, when you're doing the report, you can go through your head. You can go all through the order that you have, and that way you're not going to miss anything to write down. Okay, so I don't know if you remember from year 1 of vet school, anatomy class, and this is what it looks like, an abdomen in a dog. So they took out the bladder's right here. And so here we have the intestines. Here we have the left kidney, spleen, stomach, and liver. Oh, sorry. Let me go. There you are. If we take the first layer out, liver. Here we have the tail of the spleen, the head of the spleen, stomach, left kidney, and intestines. So I wanted you to show this, or I wanted you to see this, because that way you have an idea of what you're looking when you're doing an ultrasound. Okay, so I'm going to tell you my order. Again, I think it's something that is very personal. For me, it's very easy to follow it. So I always start with so you get what I always start with take a look if they have any thrombos. I look at the medial iliac lymph nodes, which are over there. Then I move cranially following the aorta, and I look at the left kidney. Caudal to the left kidney, I'm going to take a look at the ovary, if they're not spayed, obviously. Then I move a little medial, and I'm going to take a look at the adrenal gland. Later, I'll go over how, like where they position and everything. Then I go cranially, and I look at the spleen. Then we go a little bit ventral, take a look at the stomach. Then cranially, I take a look at the liver. And then I swipe all the intestines all through the mid-abdomen. Also with the lymph nodes that we're going to find there. And finally, before I turn them over and before I take a look at the other side, always take a look at the testicles, obviously if they're not neutered. This is something that for me it's important to do and to place it at the same order because it's something that is not in the abdomen. So a lot of times we forget. And I have to say, I forget, obviously. We're not perfect. So I think it's always good to put it in the order because that way you don't forget to do it. So then we turn them over and we take a look at the right side. The right side, I start with the intestines where I left it in the left side. I take a look at all the intestines and the lymph nodes that we have there. Then I move a little bit dorsally to take a look at the adrenal gland, right kidney, and right ovary and right uterine horn, obviously if they're not spayed. Then I move cranially. I take a look at the liver, obviously the right side of the liver. Take a look at the stomach. It's important that you take a look at all, like the whole organ, even from the left side and the right side. And finally, I take a look at the pancreas. So I want you all to acknowledge that today we're doing a 60 to 90 minute little or webinar. It's not a course. So we can't cover everything. I'm going to try to be as schematic as possible. I'm going to try to be direct, but we can't cover everything. So today what I did is we're going to cover the mostly seen and most prevalent features, okay? So how organs should be. Let's start with the bladder. So the wall in dogs, it varies, the thickness varies with distension. This is the article that you can find it. What is important here for you to know is that depending on the distension, you're gonna have a thickness, different thickness. This is important because a lot of times we have empty bladders and you might think, oh, is this very thickened wall? And it might not be. It might just be that it's completely empty. In cats, should be less than 1.7 millimeters. And it is layered, but sometimes it's very difficult to define. The urine should be anechoic. And here you can see on the left side, we have a cat. On the right side, we have a dog's urinary bladder. And as you can see, it's very thin. And the layers that you might see there, it's difficult to find when it's completely full. Uterus. This is something that I remember in the States. Most of dogs and cats are spayed and neutered. So it's something that you might not see very often in the States and other countries, which hopefully someday it'll be in most of the countries. But in Southern European countries, we still have a lot of dogs and cats that are not spayed and neutered. So it's important to not to forget that we have to take a look at the uterus. So where is it? It's ventral to the bladder and it's dorsal to the colon. So what I usually do is I go a little bit ventral to the bladder. If you see the colon, then you went too far. So right there, you're going to see the body of the uterus. Then you can follow it through the horns. Obviously, they're not spayed. What should it look like? Well, it's a hypoechoic tubular structure. Obviously, this is going to depend on the cycle, of the moment of the cycle. 5 out of 6 months, you're going to be in diestrus or in estrus. And it's going to be, again, hypoechoic tubular structure, not layered, with no luminal content. And then it's going to be 1 to 1.5 months out of 6 that you might be in proestrus, estrus, and early diestrus, where you're going to find a layer wall and some luminal content. This is very important that you ask the owner when was the last heat. And I have to say, a lot of times they don't know. But this is important because if you find some luminal content and it's in diestrus or in estrus, it's not normal. If you do find it in proestrus, estrus, or early diestrus, then it could be normal. So this is what it looks like. On the left side, we have a normal uterus. On the left side, it's also normal uterus. You can see a little bit of layering here. So probably in this case, it was probably early diestrus. The prostate. So it's caudal to the bladder. And sometimes it happens very often when we have a very large dog that has been peeing all over the garden in front of the clinic, and then they come inside and the bladder is completely empty. It might be very difficult to visualize it. So don't get nervous, it happens. So a lot of times what I do is then I wait, I do the rest of the exam, and at the end I try and look at it again to leave it a little bit of time for the bladder to fill a little bit. What should it look like? Well, in intact dogs, it's going to be homogeneous, and the echogenicity is going to be a medium echogenicity, but it's going to change with age. So it's going to increase its echogenicity and its size. There's a little formula that you can find. I didn't put it because I didn't want you to bomb you with different things, but you can try and find that little formula. It goes by weight. Then in neuter dogs, it's going to be small, it's going to be homogeneous, and it's going to be hypoechoic, as you can see here. So this was, I would say, a medium-sized dog, and as you can see, very homogeneous, hypoechoic, and not too big. Lymph nodes. I'm not going to go over all the lymph nodes that there are in the abdomen because we could be here until tomorrow. But the main, this is a little scheme, a little diagram of where they are. But the main ones that you're always going to see are going to be these, which are the medial iliac lymph nodes. As you can see, this is the aortic bifurcation. And then these, which are the either jejunal lymph nodes or mediastinal lymph nodes, they're the same. So, medial iliac lymph nodes, jejunal lymph nodes. Okay, kidneys. So, the left kidney is going to be caudal to the splenic head, and the right kidney, which we all know that is more cranial, it's going to be in contact with the hepatic caudate lobe. What should they look like? Well, let's start with the size. In cats, they're going to be between 3 and 4.5 centimeters. In dogs, it completely varies with the size of the dog. So there's an article where they did this ratio with the aorta. So you measure the kidney, the length of the kidney, you measure the aorta, the diameter of the aorta, and that ratio, if it's less than 5.5, then you have a small kidney. If it's over 9.1, then you have a large kidney. I think this is very helpful because a lot of times we are not sure, especially with big dogs, that we're not sure if we're looking at a big kidney, or with small dogs if we're looking at small kidney. I think it's very helpful. The cortex should be hypoechoic, or it's usually hypoechoic to isoechoic to the liver, and it's hypoechoic to the spleen. The medulla is going to be hypoechoic to the cortex, and the renal pelvis should be less than 2 to 3 millimeters. The ureter, you should not see it. So when it's normal, it's not usually seen. This is very important for you to remember. So probably you all know, but echogenicity, we're going to start with the spleen. The spleen is a more hyperechoic, then it's going to be the liver. And then the liver is going to be hyperechoic to the kidney or isoechoic. But why is this very important? Because when we have a doubt if we have a hyperechoic kidney, then we can compare it to the spleen, and we can see if it's a hyperechoic to the spleen, then we definitely have a hyperechoic kidney. Same thing with the liver. And here you have normal kidneys. Here's a large Greek dog, a medium-sized dog, and a cat. So you can see the medulla is hypoechoic to the cortex, and the cortex, you can see, well, I didn't compare it here, but you can see that it's pretty hypoechoic to what a normal spleen or liver. Ovaries, this is something that a lot of people probably have never seen, but they're going to be caudal to the kidney. They're once you see one, then you're always gonna know what they look like. So what they should look like, it depends also on the time of the cycle. So when we have an estrus, an early proestrus, they're going to be small. So they're going to be 1 to 2 centimeters. They're going to be homogeneous and hypoechoic. When we start proestrus, they're going to start getting large, and they might have some anechoic areas. When we go into estrus, then all those anechoic areas are going to be much, we're going to multiply, and also it's going to be very, very enlarged ovary. And then when we start diestrus, it's going to start reducing its size in the anechoic areas too. Again, this is something that is important when you're doing an exam, because if you can see the ovaries, you're going to probably have an idea of what time of the cycle we are, and that way you're going to see if the uterus it's normal for that time of the cycle or not. Here we have the left ovary. Here, there's the left kidney. Right ovary, and right here is the right kidney. Okay, the adrenal glands. So in dogs, this is a little tip that I do. So what I start from the bifurcation of the aorta. I'm going to start following the aorta cranially, and right before the kidney, there's going to be a little artery coming out, which is the renal artery. Cranial to that artery, we're going to find the left adrenal gland. So try and exercise with that, because again, once you see the renal artery, you just have to swipe over to one side or the other, like medial and lateral, medial, lateral, and it's going to pop up. Same thing with the right adrenal gland. It's going to be caudal to the right kidney. But also what you're going to do is you're going to find the aorta, you're going to find the caudal vena cava, and you're going to start swiping in between, and then you're going to see it right there. In cats, you just have to know that they're medial to the kidney, and sometimes I've seen that most of the times they're more cranial than in dogs. What should they look like? They're hypoechoic, especially in cats. They're very hypoechoic. They might have some little hyperechoic, in cats, hyperechoic areas, which are physiologic. They're little calcifications. And maximum measures 6 to 8 millimeters for dogs and 4.5 millimeters in cats. And here we are. So left adrenal gland in a dog has the little nut. Then we have the right adrenal gland, as you can see. So this is the left kidney. This is the liver. This is the aorta. In cats, this is the kidney. So it's a little more cranial than in dogs. This is the left adrenal gland. And then this is the right adrenal gland. You can see here a little bit that hyperechoic area. This is the liver. Okay, so the spleen. The spleen head, you're going to find it in the base of a triangle done by the left kidney, the stomach, and the liver. So right in that base of the triangle, you're going to find the head of the spleen. And you're going to have to swipe the whole organ to make sure that we don't miss anything, because we have to make sure that if we follow everything, we don't miss any abnormalities, because sometimes they're going to be very, very small, and they might be in the tail or they might be in the body. So please follow the whole organ. Normal aspect, it's the most homogeneous organ that you're going to see, and it's going to have a hyperechoic capsule, and it has a very fine epitexture. Here you have one of the cat, hyperechoic capsule, and here is the spleen, hyperechoic capsule, and the spleen. I have to say, with the Mindray M9, the quality of the image is so good that you might think from these images that they're a little bit heterogeneous, but they're not. I think it's something that, again, the quality of the image is so good that sometimes you see everything. Once you see it live, you're not going to have that impression. But this is kind of like when we all started with digital x-rays, that we thought that all the dogs had bronchial pattern. Well, this is the same thing. But again, these two are normal spleens. Okay, the stomach. The stomach is going to be caudal to the liver, and it's going to be layered. You're going to have a hyperechoic serosa and a hyperechoic submucosa, and a hypoechoic muscular and a hypoechoic mucosa. It has rugal folds. That makes it hard sometimes to, when the stomach is empty, sometimes it makes it hard to measure the wall, but when you can measure, it's going to be less than 5 millimeters in dogs and less than 4 millimeters in cats. Same thing as with the other organs. It's very important that you scan the whole organ. That you start from the fundus, which is closer to the liver, you move all the way through the body, which is going to be dorsal and caudal. And then on the right side, you're going to look at the pyloric area. So here we have the fundus, this is the liver. Here we have the body and the pyloric area. You can see this is the liver. Intestines. So with intestines, I'm going to go through all the different segments. I think it's hard at the beginning to know exactly or to differentiate between the segments. Some of them are going to be easier, some of them are not. I'm just going to give you a few tips, but I think exercising a lot is going to help you. So duodenum, you're going to find it on the right side. It has a rectilinear course and is the thickest segment in dogs. So it's going to be less than 4.4 millimeters in dogs and less than 2.2 in cats. The main thing in the duodenum is that 2/3 of the wall are mucosa. So most of the wall, you're going to see the big mucosa, big hypoechoic layer. The jejunum is similar, it's very similar, but it doesn't follow a rectilinear course, so it's going to do some loops. It's a little more in the mid-abdomen, but especially you can see that it does some loops. It's a little thinner, so it's going to be up to 3.8 millimeters. And in cats, the mucosa is only going to be half of the wall. And then the ileum. The ileum, for me, it's a little easier to differentiate from the other two, especially because you can try and look for the ileococcylic junction and then follow the whole ileum. But the main thing is that the layering, they have similar contributions, so they're not going to be all mucosa. In cats, though, this is the thickest segment. So it's going to be the submucosa and muscular are going to be more prominent, and in cats, you're going to see again that this is the thickest segment. And then you're going to see the colon and the cecum. The cecum usually is filled with gas, so unless it's very abnormal, you're not going to be able to see it very well. Examine it very well. And then again, you look for the ileococcylic junction. And then you're going to start the ascending colon. And on the left side, you're going to see the descending colon. It's going to be filled with feces. And the wall has layers that also are similar in contribution, but the wall is very thin. It's up to 1.5 millimeters. So here you can see the duodenum, rectilinear course, the left kidney. You can see that the mucosa is covering most of the thickness of the wall. Here, I want you to see this because I want you to acknowledge the importance of fasting. When we have a bowel, a lot of veterinarians say, "Oh, yeah, he ate this morning, but it doesn't matter because it's not anymore in the stomach." Well, it does matter because when we have a bowel filled with a pattern that is ingesta, so it's a food pattern, we're not going to be able to see the wall completely. So I think it's very important for you to know that this is what it's going to look like. So as you can see, yeah, maybe this is probably this is the jejunum, but again, with the food inside, we're not going to be able to do a good exam. And then these two are the jejunum. You can see that they're very similar to the duodenum, but they do loops. So you're going to see little cuts like this. Then here we have the ileococcylic junction, and here you have the ileum. This is where the colon starts. This is the colon. So you can see the feces, you can see the wall, and I want you to see here it's 1 millimeter in this case. So it's a very thin wall. Okay, the liver. So this is a little diagram of where you're going to see subcostal. So the left side, we're going to see the left lobes and the quadrate lobe with the gallbladder. On the right side, we're going to see the right lobes, the quadrate lobe with the gallbladder, and we're going to see the caudate lobe, which is the more caudal lobe. There you can see this is where the kidney stays. Okay, so as you say, as you know, it's subcostal and cranial to the stomach. Its size is very subjective to know to see the size, but the most helpful thing that you can see is that the tips should be pointed. So if you have around the tips, you're going to know that it's an enlarged liver. It's hypoechoic and heterogeneous parenchyma, especially compared to the spleen, and it has a coarser echotexture compared to the spleen too. This is something that is very helpful also to remember, is that the vessels in the liver, they have a hyperechoic wall, and this is good to remember, especially when we have a big mass that we don't know the origin, we don't know if it's part of the spleen or part of the liver, because when it's lost all this structure, you can't find it, or it's very, very big. You have to try and see what is the attachment. If you see hyperechoic wall of the vessels, then you know that you're in the liver. Then the gallbladder has an anechoic content, or should have an anechoic content. Sometimes, I have to say a lot of times, you're going to see sludge, which is hyperechoic sediment. But a lot of times you can see it in asymptomatic dogs and cats, and especially when they're fasted. The wall should be less than 1 millimeter thick, and it's going to be empty or less full after they've eaten. The common bile duct is going to be dorsal to the portal vein, and it's going to be ventral to the duodenum. So you can swipe a little between the portal vein and the duodenum, and you're going to see it right there. It's less than 4 millimeters in cats and less than 3 millimeters in dogs. So here on the upper left, we have a normal liver with a gallbladder and the hyperechoic vessel wall. Normal liver, gallbladder, hyperechoic vessel wall. And then I want to show you this. You're probably going to think, like, well, that is not a very good image. I want you to see this because this is on the right side, and especially with large breed dogs, you're going to have to you're not going to be able to go subcostal. You're going to have to go intercostal. So you're going to have to put the transducer in between the ribs. So the image is going to be, obviously, the acoustic window is going to be smaller. So this is a rib. This is another rib that you can see the shadowing. And this is what you're going to look at. So in order to look at the whole liver, you're going to have to jump between one intercostal space and another. Okay, testicles. Again, a lot of people probably haven't seen it. So you shouldn't, they should be in the scrotum, and you should never clip or put alcohol. Just with the gel is very good because they get very irritated. They are of a medium echogenicity, and they're pretty homogeneous. They should be symmetrical, and they have a central hyperechoic line. This is very helpful when you're trying to look for ectotorchid testicle. So we're trying to look in the abdomen or in the inguinal area. This is what is going to tell you that you're looking at a testicle and, for example, not a lymph node. The epididymis runs dorsally, and it's hypoechoic with a coarse echotexture, but you're not going to usually examine it unless it's abnormal. So this is what a testicle looks like. This is a small testicle, but it was from a small dog. But you can see here the hyperechoic line, and then they're hypoechoic and pretty homogeneous. Okay. So the left lobe of the pancreas is not usually seen. It's going to be in a little triangle between the left kidney, the stomach, and the spleen. They're going to find it right there in the middle of that triangle. Don't sweat it out if you can't find it, because it's not usually seen unless it's abnormal. The body, you're going to find it in the right cranial abdomen, close to the pyloric region. You're going to find it between the liver and the pyloric region. And the right lobe is going to be dorsomedial to the descending duodenum and ventral to the right kidney. So what I usually do is I start from the duodenum, start going dorsal, if I get the right kidney, then I went too far. So right in the middle between those two, you're going to see the right lobe. So normal aspect is going to be homogeneous. It's going to be isoechoic to mildly hyperechoic to the liver, but it's very poorly distinguished from the mesenteric fat. So you're going to have to make an eye on doing it like all the times, trying to find it, because it's at the beginning it's hard to see. Pancreatic duct is not usually seen in dogs because it's very small. As you can see, it's 0.6 millimeters, and in cats it's going to be less than 1 millimeter. And then the mean right lobe, it's less than 8 millimeters in dogs, less than 4.4 millimeters in cats. So here you have the right lobe of the pancreas. This was in a cat. And here you have the right lobe of the pancreas. This was in a dog. Okay, now we're going to go through the abnormal findings. Again, we're going to see the mostly seen and most prevalent disorders. We can't go through everything, so we're going to see the ones that are going to see the most. Oh, sorry. Okay, bladder stones. So, we're gonna, with the bladder, we're gonna go through different abnormalities in content and abnormalities of the wall. So we can find some bladder stones. Bladder stones are gonna be hyperechoic with a distal shadow. Most of the time, sometimes you're not gonna see it. And you're gonna find a twinkling sign with the color Doppler. For urethral stones, they're more or less the same, but obviously in the urethra. And if you see dilation of the urethra, then there's some obstruction. Then finally, some gas. So you might see gas in emphysematous cystitis, diabetes, but this is also important for you to remember. If the dog or the cat has been catheterized, you might just have gas because of the catheter. And it's going to be luminal. So it's going to be inside the bladder. Then alterations of the wall. So you might have cystitis, which is a thickened wall. It's going to be hyperechoic. It can happen either way. And you're going to see the layer wall. It's usually cranioventral. And you might see polypoid cystitis. Polypoid cystitis, you're going to see pedunculated areas, and they're usually cranioventral. And then finally, you might see a neoplasia. It's an irregular, usually an irregular mass, mixed echogenicity. It can happen in any region, but most of the time you're going to find it in the trigone or the cranioventral area. Important for you to remember that it depends on the distension of the wall. So as we said before, the thickness depends on the distension. So make sure that you have a full bladder in order to really visualize and be able to see that there is a thickened wall and not only an empty bladder. I hope you can all hear me because I see that they're popping up in the chat, so I hope that you can hear me.
Sarah, I can hear
you. Can hear me?
Your question.
Okay. Yeah, no, because I can see the chat coming up. And,
no.
So
they are placed some question, but about your voice is at the moment is perfect.
Okay, good. Okay, so here we have some bladder stones. So you can see here, hyperechoic with a shadow, and then we have the twinkling sign with a color Doppler. Here we have a polypoid cystitis, where we have a little polyp in the cranioventral area, and this was a urethral stone. In this case, it wasn't dilated the urethra, so it wasn't making any obstruction at the moment. Okay, uterus. So what are the abnormal findings? Pregnancy, obviously, and something that you have to remember is the uterine involution is going to take 3 to 4 weeks in the dog and 24 days in the cat. This is important because a lot of times they bring you the dog or the cat with some discharge, vaginal discharge. So when you see it, if it's only been 2 weeks and you still see some content in the uterus, it can still be normal. So just make sure that you remember that the involution can take up to 4 weeks. You're going to see cystic endometrial hyperplasia. As you all know, it's a hyperechoic uterus with high anechoic areas. And you might see some abnormal content, as you'll know, pyometra, hemometra, hydrometra, mucometra. It is not possible to accurately distinguish with ultrasound. You might have some hints with depending on the type of liquid that there is. So if it's very anechoic, it could be hydrometra, but it could also be a pyo. If it's carpusculated, it could be anything. But again, just make sure that you can't accurately distinguish between all of them. And then you might find neoplasia, as with every organ. Remember, the cystic endometrial hyperplasia can become a pyometra, hemometra, hydrometra, or mucometra. This is something for the owners to know, because a lot of times we do it, we say it, and they're completely calm with that. Oh, okay, it's not a pyo. Well, in 2 weeks, it can become a pyo. So just remember to tell the owners that. So here we have a little fetus. Here we have what I think in this case it was a pyo. So a lot of content with dilated uterus. And here is the bladder. We have a spayed animal that was spayed after when it was already old. And in this case, they didn't do any further exam to know what it was. In my opinion, at that moment, it was probably a neoplasia. It was very irregular. It was pretty vascularized and is very irregular and very hypoechoic. So, and dishomogeneous, as you can see. So in my opinion, it could be a neoplasia, but they didn't want to do any further testing. So we're not gonna know. Okay, the prostate. So with the prostate, we can have benign prostatic hyperplasia. You're gonna find a hyperechoic prostate with or without anechoic areas, which are intraparenchymal cysts. You might see prostatic and paraprostatic cysts. You can see prostatitis, which is often not possible to differentiate between prostatitis and benign prostatic hyperplasia. You might see abscesses, which are usually complication of prostatitis. And you can see also neoplasia, which is usually in near dogs. So here we have an abscess, as you can see right there. This was a little cyst. This was a big abscess. This, I put this because this was in a Cushing, and a dog that had Cushing's disease. So we have all the calcifications of the prostate. And then this is a benign prostatic hyperplasia. Lymph nodes. Lymph nodes can be either reactive or neoplastic. This is something that you have to remember. You can't differentiate just with basic ultrasound between the two of them. You would have to do contrast enhanced ultrasound and fine needle aspirate. You can't say, oh, yes, this is a neoplasia. You can definitely put it on top of the top of the list and say, with the whole picture of the clinical case, this is probably a neoplasia, but you can't say for sure. So don't forget to put the other diagnostic just in case. So if you want to know what it is, you should do contrast enhanced ultrasound and a fine needle aspirate. And then here we have a reactive or neoplastic colic lymph node. It's hypoechoic and enlarged. Here we have a medial iliac lymph node. You can see it's 9 centimeters. And this is a difficult case that I've been seeing. And this was is a giant schnauzer. And I really thought that and when I saw it, that it was going to be neoplastic. Apparently, it's a fungal disease. So as you can see, again, you can't see it. It's pretty dishomogeneous, and it's very, very big, but you can't see it. And then this is the splenic lymph node. You don't usually see them. So in this case was also reactive or neoplastic. Okay, the kidneys. So we might have hyperechoic kidneys. If it's the cortex, we're going to have acute renal disease. If it's the cortex and the medulla, it's probably chronic disease, and that is going to have reduced corticomedullary junction. It can also be with kidney with no disease or with an early disease. So you just have to put it and write down that the kidneys are hyperechoic. But you have to put it all together with blood work and clinical signs. The size, if they're enlarged, it's an acute renal disease. If they're small or normal, it can be a chronic kidney disease. They can also be irregular. Then we're going to have nephroliths, so stones. They're hyperechoic areas with acoustic shadowing. We can also find mineral areas with chronic kidney disease, and it's hard to differentiate between stones and those mineral areas. And then we might have some neoplasia. They can be focal, multifocal, and then a sign that is very typical in lymphoma in cats. It's a hypoechoic subcapsular thickening. So you're going to see under the capsule, you're going to see a hypoechoic line. So here we have chronic kidney disease. As you can see, everything is hyperechoic. Here we have a reduced corticomedullary junction. So this is a normal kidney. You can see that the junction here is much better. And here, yeah, you can see it that you can differentiate the medulla and the cortex, but it's reduced from this one. Okay, kidneys can also have cysts. Cysts can be from chronic kidney disease, or they can be specific of breeds, like the Cairn Terrier or the Persian. You can see abscesses, and you can also have palictasia. So palictasia is a dilated pelvis, and palictasia can be secondary to different things. First of all, obviously hydronephrosis. So when we have an obstruction, you might see also the dilated ureter. You might see or might not see the cause of the obstruction, but it can definitely be one of the causes. The other cause could be pyelonephritis. And then another thing, and this is something for you to remember, is that a dog or a cat that has been on fluid therapy or is taking a diuretic therapy or even a chronic kidney disease can have palictasia. So don't think that if you see dilated renal pelvis that we have to look for the obstruction or he or she has pyelonephritis. Sometimes we have to talk to the owner and talk to the vet to see blood work and to see what they've been doing in the past few days. So dilated ureter and dilated pelvis. This was the same dog. And anechoic cyst. Okay, the spleen. So the size of the spleen is going to be pretty subjective. So sometimes you just have to do a lot of ultrasounds to know what a spleen should look like. But a tip to look for is the margins are going to be rounded. So in the spleen, margins should be pointy, let's say like that. And if you see rounded margins, then you know that the spleen is enlarged. In cats, they've been doing, you can see in the panic, they say that in their opinion, a spleen that measures in thickness more than 1 centimeter, it's an enlarged spleen. And then they can also be normal in size with hyperechoic speckles. This happens in Cushing's disease, this happens in diabetes, and also happens in chronic steroid use. And this is a rounded edge, as you can see here. Instead of being pointy as it should, it's very rounded. This is a dog that I'll show you later, the rest of the parenchyma. So I'm not going to go through all the causes because this is just a list of names. So I think there's something you just have to remember and learn. But I'm going to go through how how a spleen that is enlarged can look like. So a spleen that is enlarged can be normoechoic, and these are the causes. It can be heterogeneous, and these are the causes. It can be hypoechoic, which is less, I have to say, less often you see this. So you only have two options. Either it's torted, so there's a torsion, or it's a neoplasia, most of the times lymphoma. This is what it looks like when we have an enlarged spleen that is heterogeneous. So especially this one, you can see all the different areas, and here you can also see all the different areas, but they shouldn't be there. Okay, then we might have focal and multifocal lesions. They can be hyperechoic, hypoechoic, mixed echogenicity. They can be also large masses, and those masses can be anechoic or heterogeneous. But you would have to do further testing to differentiate between all of them. You can't say for sure if you see an area, a hypoechoic area, they say, oh, it's probably a benign hyperplasia. You can't say it for sure. So please do further testing, obviously if the owner wants, but don't put yourselves in a position that you tell the owner it's probably something benign, so let's just hold off and see, and then in 3 months we recheck, maybe in 3 months it's going to double its size and maybe it was malignant. So in my opinion, always offer to do further testing. And in this case, we always recommend to do contrast ultrasound and to follow following a fine needle aspirate. So here you have like a little nodule, 1 centimeter, heterogeneous, and then a very heterogeneous and large mass. You can see here, I could follow that this is the spleen. Okay, liver. We are going to have abnormalities in size and contour, in echogenicity, and depending on the distribution of the abnormalities. So we're going to see the three different scenarios. So very important. If you want to do a good diagnosis, you have to put together the ultrasound findings, clinical presentation, blood work, and contrast ultrasound with FNA and or biopsy. Why is this important? Because you can't do a complete diagnosis. Obviously, most of the times you're going to have a clinical presentation and your findings. I would say 50 or 60% of the times you have blood work, not always. So please always ask your veterinarians to do blood work before we do the ultrasound. And once you have this, you can't do a complete diagnosis just with these. You might, or you're going to have to do this. This is, again, to have a complete diagnosis, okay? Okay, so abnormalities in size. We can have a diffuse enlarged liver. This is a list of causes. We can have only one lobe or a focal enlarged area. These are the causes. And we can also have a small liver. These are the causes. Obviously, with a small liver, the age of the animal and clinical signs is going to give you some hints, obviously. So this was a dog. It had cirrhosis, but as you can see here, it's a small liver, very pointed tips right there. It also had ascites. This is a case that when I saw it, I put differential diagnosis, I put fibrosis, cirrhosis, and shunt. It went to 5 different places. All of them did ultrasound. No one did a CT because the owner was a little hesitating to do it. So most of them, they said cirrhosis. I think even if at the end it was cirrhosis, I think it's always very important that you put all of the differential diagnosis, because without, in this case was a CT, so they did a CT, they saw that there were no shunts, they took a biopsy, and then they saw that it was a cirrhosis. So you can't say it just by ultrasound. Okay, abnormalities in echogenicity. So we might have hyperechoic liver, hypoechoic liver, or mixed echogenicity. Even if you have a mixed echogenicity, it can be hyperplasia, which is benign, it can also be hepatitis, but it can also be neoplasia. This was a diabetic cat. It was I know you can't see it here, but it was a little enlarged liver, but especially it was very hyperechoic. And this was mixed echogenicity liver. They didn't do any further testing, so we're not going to know what it was, because a lot of times it just happens. They don't want to do anything else. So, and then you can find focal or multifocal lesions. They can be hyperechoic, as with the spleen, hypoechoic, anechoic, or mixed echogenicity. The same thing as with the spleen. You have to do further testing to know what it is. Okay, so here you can see hypoechoic area, mixed echogenicity, and an anechoic area. I put the color Doppler to make sure that it wasn't vascularized or there wasn't a vessel like a dilated vessel or anything like that. Okay, the gallbladder. So with the gallbladder, you can have an obstruction. With an obstruction, you are going to have a tortuous common bile duct. Is going to be dilated, so it's going to be over 4 to 5 millimeters in cats, and over 3 in dogs. And you're not going to be able to distinguish from chronic inflammation, because as you can see here, one of the causes of obstruction can be inflammation. You're also going to have the too many tubes pattern, so a dilation of the hepatic ducts. You can also have, again, from causes inflammation, especially with pancreatitis in cats, the triaditis. You can have edema, you might see plugs, and you can also have stones. Abnormalities in the wall. It's a wall that's it's measuring more than 1 millimeter, and causes can be inflammation, edema, hyperplasia, or neoplasia. Then we can have a mucocele. The mucocele, we're going to start when it's at the beginning. You're going to see a hypoechoic mucus that displaces the sludge to the center. Then it can become stellate pattern, and then it can become also a kiwi fruit-like pattern. And then finally, we can also have stones. They're hyperechoic and they have acoustic shadowing. Here you can see mucocele, so the hypoechoic mucus that is displacing all the sludge to the center, and then the common bile duct that is a little tortuous and is dilated. Okay, the GI tract. So we're going to go over a few things that can happen. The first thing, as with other organs, is going to be abnormalities in the content. So foreign bodies. So we're going to have linear foreign bodies. You're going to see a hyperechoic line. I put there with or without shadowing. Most of the times I don't see shadowing. And here's very important thing to remember. You're going to see plicated bowel. So what is plication? Plication is something that when we all start doing ultrasounds, we get very nervous when we see an area that it might be plicated, thinking that it's going to be a linear foreign body. So let's put the difference between plication and corrugation. Plication is when the whole wall is involved. So you're going to see harmonic sign, but the whole wall from the serosa to the mucosa is involved. I'll show you a picture now. With corrugation, you're only going to see part of the wall involved. So the serosa is usually normal and straight, and the mucosa and submucosa are usually the ones involved. Okay, then we can have other foreign bodies, which are they're going to be in different shapes and echogenicity. And we might have a perforation. So when we have a perforation, if you're lucky, you're going to see a focal loss of layering. But don't worry if you can't see it, because what you're going to look at is you're going to try and find the hyperechoic fats surrounding that area. Okay, so that is going to give you a hint that it might be perforated. So what is important to know about foreign bodies? Well, we have to make sure that it's not obstructed, because this is going to tell us what we're going to do, the next step, what we're going to do next. So when we see an obstruction, we are going to have a dilated bowel filled with fluid, maybe gas, and it's going to be cranial to a foreign body. Okay, this is important. So why is this important? Because it's going to tell us, do we have to go to surgery? Or can we just do some high fiber diet and maybe recheck it tomorrow? This is very, very important for you. And then it's very important also to know and try and figure out what segment of the intestinal tract the foreign body is, for a few reasons. First of all, because if we want to recheck it, we want to know if the foreign body is moving. So we say, okay, today's in the duodenum, and then in 2 days we see it in the ileum, then we know that it's been moving. So that's a good sign. If we know this in the ileum right before the ileocephalic junction, yeah.
We lost for 5 your voice.
Okay. Okay. So again, with the obstruction, it's important for you to know if it's obstructed or not, because it's going to tell you what is the next step going to be. So are you going to send it to surgery? Are you going to do a high fiber diet and recheck it? It also is going to depend on the clinical science, obviously, but for you, it's very important to make sure that there's some obstruction or not. With the obstruction, you're going to see a dilated bowel filled with fluid and maybe gas. And it's going to be cranial to the foreign body. And then again, the segment of the intestinal tract is very useful for you to know. First of all, if you're going to recheck it, you're not going to go to surgery, you're going to recheck it, then it's good to know if it's been moving or if it's in the same place. Because if I do it today, it's in the duodenum. Do it in 3 days, it's in the ileum, we know it's been moving. If it's still in the duodenum, we know that after everything we've been doing, it hasn't moved, probably not going to move. Also, it's important for the surgeon. That way, obviously, they always check everything, but it's also good to know where it is. It's hard. I'm not going to lie. It's hard a lot of times to know exactly where it is. Try and follow the bowel where it is, because when the foreign body, exactly the bowel where it is, you can't see it, but if you try and following it, you might see a normal bowel and try and figure out where it is. So here we have dilated bowel filled with fluid. This was an obstructed bowel. Here we have a foreign body. This is some liquid. This is the wall of the intestine. So you're going to see that it doesn't follow the wall. This is the difference between feces and also gas and foreign bodies. And then, as I was telling you before, so this is a linear foreign body, maybe a little bit of shadowing. And then this is plication. The whole wall is involved in the plication. Okay, so cirrhosis of mucosa, muscular cirrhosis, everything is involved. Okay, we can also see intussusception. It's actually pretty cool when you see it. I think it's an image that I really like. Obviously, for the animals, not the best thing, but I think it's a cool image. You're going to see the typical onion-like image. It's a multi-layered area. The outer bowel is going to be thickened and hypoechoic. And then the inner bowel, it's probably going to be normal. And you might see some fat inside. You have to scan everything, several planes, to avoid confusion with plication or the ileocephalic junction. You can also have an intussusception of the ileocephalic junction, but you have to make sure that when you're doing it, it's actually intussuscepted and is not another, like an artifact of just swiping. So here you have it. Outer bowel is thickened and hypoechoic. Inner bowel is pretty normal, and then the fat inside. Okay, and now abnormalities of the wall. So we can have inflammatory disease. They usually, and again, usually are extensive and symmetrical. The wall is extensive and symmetrical thickening, but this is usually not always. And you most of the times have conservative layering. Again, usually. So with gastritis, so inflammation of the stomach wall, you're going to have either hypoechoic or hyperechoic. They can be focal or diffuse, and you might see some gastric edema. Enteritis, so inflammation of the small bowels, mostly diffuse, affecting several segments, but not always. The thickening of the wall is usually has conserved layering, but if they're very severe, they can definitely lose the layering. You're going to have a hyperechoic mucosa, especially with chronic enteritis. And you might see speckles, like they're called mucosal speckles, which are hyperechoic spots. It can also happen with IBD, but they can happen also post-prandial, so they can happen after they've eaten. So very important also that they're fasted. And then you can also see hyperechoic lines that are perpendicular to the lumen. And as we said before, you can see corrugation, not plication. So remember this. When it's plicated, there's a foreign body. When it's corrugated, it can definitely be enteritis, and that's it. You can see colitis, which is inflammation of the colic wall. And you're going to see a thickened wall with or without visible layering. So here we have colitis. This, I don't know if you remember from the normal findings of the colon, you can see the wall was very, very thin in the layering. You could see it, but very subtle. Here you can definitely see the layering, and the wall is pretty thickened. Here, another thickened wall. A little bit of corrugation, just a little bit with thickened wall, and here you can see corrugation. So serosa and muscular are normal, mucosa and submucosa are involved, okay? So very important to differentiate between the two of them. Another abnormality of the wall, obviously, neoplasia. So we might see, well, actually, we're going to see a thickened wall with loss of normal layering. We might see pseudo layering in gastric carcinoma. Is not very often that you see it, so don't sweat it out. You're going to have decreased motility and have this is important to know, but again, you can't say for sure when you see a bowel that is abnormal, that is thickened only one segment, and it's and has lost its layering. You can't say for sure. Sometimes you're going to put it on top of your list, but you can't say for sure without any either biopsy, contrast ultrasound, or FNA. With large masses, when they're very, very large, especially with cats, you need to confirm GI origin. And this is important because if you, with a lot of, with cats, you might think that there are lymph nodes, or you're not sure if there are like for example, lymphoma, right? We have enlarged lymph nodes and you're not sure if what you're looking, it's a mass in the bowels or the lymph nodes, and that is going to definitely change, especially in the treatment. Are you going to go to surgery? You're not going to take the lymph nodes out. So this is important for you to confirm. How are you going to do this? You're going to try and look for the gas in the lumen. So you're going to see a reverberation artifact. And you're going to have to try and see a connection to the bowel. So here we have a mass, very thickened wall, hypoechoic. This is the lumen. This is the lumen. And this is the lumen. So in this case, I was able to follow the bowel. Most of the times you're able to follow it like a normal segment, or a segment that it has normal layering, or almost normal. And here you can see normal bowel, almost normal bowel. And here you can see it was a pretty large mass. This was a cat, it was a 4-centimeter mass. Testicles. So you can have them cryptorchid, so you can have a testicle inside the abdomen or inside the inguinal area. Please always check both. A lot of times the vet says, I didn't see it in the inguinal area, so it's in the abdomen. I'm sorry, I'm not I'm not saying that they're lying. Yeah, a lot of times you can't feel it. So always check the inguinal area. You can start from the inguinal area and then move to the abdomen, or the opposite. I don't care. Obviously, if you find it in the abdominal area, then you're going to have to look in the inguinal area. But if you can't find it, always check the inguinal area. So when you're looking for them in the abdomen, you're going to start from the kidney. So caudal to the kidney where the ovaries are. And you're going to start going towards the inguinal ring. So you're going to follow the same path as the testicle does when it's descending when they're a fetus. So you're going to do that. And I usually, and this is usually, find them very close to the bladder. So either cranial to the bladder, dorsal or ventral to the bladder, or right in the inguinal ring. How are you going to know that you're looking at a testicle? Well, they're hypoechoic, maybe sometimes hyperechoic, but they have a hyperechoic central line, as we said before. So this is what it's going to tell you that you're looking at a testicle and not, for example, a lymph node. You're going to see also some neoplasia. They're nodules or large masses, but you're not going to be able to differentiate between the type of tumor. So you're not going to be able to know if there's the type of tumor that is not very likely to metastasize or not. So please either take them out or do some other testing. You can have some inflammation, either orchitis or epididymitis. You might see cysts, and you might see also torsion, which you're going to see it decrease blood flow with a color Doppler. So here we have a cryptorchid testicle. This was in the inguinal area. You can see this is a muscle. And here, a hypoechoic oval area with a hyperechoic central line. It was pretty small, as you can see here. I don't know, but I can tell you it was probably like 1.5 centimeters. And then this is a little nodule, not so little nodule. This was a case that when I came, they said it's probably orchitis because it was an enlarged testicle. It was very painful. But once I looked inside, this is the normal testicle, or not, I mean, it's a little bit altered, but it wasn't very, very big. It's almost 2 centimeters. The problem was epididymitis. So this was the epididymis. It was very enlarged and hypoechoic. Obviously, we castrated and everything was good. And then finally, pancreas. So the big P, right? The ones that we're always, when we're starting, we're always trying to look for. So we can have acute pancreatitis, and that is going to be, you're going to see a hypoechoic pancreas. It's going to be enlarged. You're going to have hyperechoic surrounding fat. This is what is going to tell you that you have pancreatitis. In dogs, usually involves the right limb. In cats, usually involves the left limb and the body. In order to know if it's a necrotizing pancreatitis, you have to know that there's necrosis, and for that, you have to do contrast ultrasound. You might see other anechoic areas. You can't say for sure that it's necrotic, so you would have to do contrast ultrasound. And you're going to see irregular margins. You can also see chronic pancreatitis, and it's going to be a dyshomogeneous parenchyma with hyperechoic areas. You can also see edema, either with pancreatitis or also with hypoalbuminemia, and you're going to see hypoechoic stripes. You can see cysts, which can be also from pancreatitis. It can also be congenital. And then you might see abscesses. So this was an acute pancreatitis, hyperechoic fat with a hypoechoic parenchyma. In this case, it was a dog. So you're not going to see the duct is usually very dilated in cats. Okay, then I'm to end this presentation, I'm gonna put a few clinical cases. So Pedro, it's a 10-year-old Labrador retriever. He's diabetic, diagnosed a few years ago. He's also epileptic with an ongoing therapy with phenobarbital. But lately, his diabetes hasn't been under control. So his glucose has been very high, even after changing the dose of insulin. So we do an ultrasound, and we find a little bladder stone. Not very important or not very concerning. Here, I want you to see the adrenal glands, because a lot of dogs that have diabetes can have also Cushing's disease, and it gets worsened with that. So in this case, the adrenal glands were pretty normal. The liver was not too bad. It was a little bit enlarged, not too bad. But Obviously, there was food inside his stomach. And when I tried to look for the phthoric area, this popped out. This here, this here, this here. So this is a mass of the phthoric area. So a mass in the gastric wall. It was a 4 centimeter wall, 4 centimeter mass. So what this was causing, it was causing the stomach not to empty properly. So he always had food inside his stomach. So his glucose was always high because he always had food. It was as he was always eating. So this was the main thing. I have to say in this case we were lucky, and the veterinarian was very proactive, because usually the usual plan would have been, let's do a glucose curve, and probably they would have seen the glucose high due to the decreased stomach emptying. Maybe they would have changed the insulin, but maybe not. They would have seen an ultrasound. Without an ultrasound, we would probably never find the cause. So just as a note, I recommended further testing. They didn't do it, but the patient is still alive, and it's much better control after changing his insulin. So this is important. If they had done the change of the insulin, then probably the dog would have been much better, and they wouldn't done anything else, and we wouldn't have an actual diagnosis. And then the clinical case number 2, Ruby. Ruby is a 2-year-old mixed breed. She was spayed at the age of 1, maybe a little bit earlier. But in the past few weeks, she's been having vaginal discharge. It wasn't hemorrhagic, so she wasn't in heat. And as you can see, there were no signs of heat. She was just having some discharge. So we do the ultrasound. This is what we find. This is the bladder. This is the urine stump. So here the uterus was taken out, but this is what it was left. It was a 2 centimeter mass. I'm going to say mass because we don't know what it is. It was vascularized. And in the ovarian regions, we see this. So we see this area, 1 centimeter. 1 centimeter, this was left, this was the right. It was, 1 centimeter. Some hyperechoic areas inside. As you can see, those are probably the sutures. There was a little bit of blood supply. So, what are the differential diagnosis? It can be an ovarian remnant syndrome, but there were no signs of heat, but still can be. They can be granulomas. They can be, it can be a neoplasia, but with the age, I'm a little bit less concerned about that, but can definitely be. It could also be a gauze or another foreign body, but it has blood supply, so it is less likely. But you have to put in the report, you always have to put all the differential diagnoses. So laparoscopy was done, and actually not laparoscopy, I'm sorry for that, it was laparotomy. It was done, and they didn't see any ovarian tissue, but apparent granulomas. And further testing and further surgery is will have to be done, because that granuloma of the uterine it was adhered to a lot of tissue, so it's not going to be an easy one. So, well, before we start, I wanted you to know what we did in this video. So we wanted to do practice for you, as you were asking, for you to know how to place the probe in the animal and also itself. It was hard for us to do a good video without moving a lot, because we checked it and we saw that when we were moving a lot, the video paused and we lost some quality of the image. So just so you know, we're not filmmakers, so we did our best for you to try and see the probe and the animal, and at the same time to try and see the image that we're looking at the screen. Okay, so I hope you like it. You're not going to hear the audio from the video. And what I'm going to do is I'm going to explain what am I doing. Okay, so here we go. Okay, so first of all, when we start, we have to place the marker. I usually place it cranially. It doesn't matter if you want to do it caudally. The important thing is that you place the marker in the screen at the same orientation. So I start from the bladder, marker cranially, aside from the bladder. Now we're going to move for you to see the image. There we are. And that is the bladder. I move, he's my dog, he's Hugo, and he's a neuter male. So I went caudal to look for the prostate, and you can see it right there. And the prostate, as you can see, is homogeneous, hypoechoic, and small. Then I moved dorsally to look for the aortic bifurcation, and to look for the medial iliac lymph nodes. And I'm gonna show it to you now. There they are. They're a little bit small, obviously, because the image is not very close, but you can see that the aortic bifurcation, right dorsal to that, you're gonna find the lymph nodes. Then I move cranially, exactly, still with a marker cranial, and right before the subcostal area, you're gonna see the kidney. In my dog, he has the kidneys a little bit deep, so I had to go deeper to see the whole kidney, because you have to make sure that you see the whole organ. And then I went a little medial, and that is where the adrenal gland is. So you can see it right there. I'm measuring it. It was normal. Obviously, I made sure that he didn't have a lot of problems. So then I'm moving also cranially, always with a marker cranial. I'm moving cranially to see the spleen. And then what I'm going to do from here, and you're going to see it now, is that I'm going to start swiping the spleen all over. So I'm subcostal, and I'm going to do all the planes that I can. So swiping everything, different planes, because we want to make sure we see everything from the spleen. So you can see in the image that I'm swiping everything right now. Then what I'm doing is you can see the spleen also going right next to the liver. I decreased a little bit the quality of the image. I took away the harmonics, because when we have a liver that in a large breed dog, you might lose a little bit of the quality of the image, so you can decrease it. And as with the spleen, you can swipe everything in all different planes. So there I am, moving everything just to make sure that we see all the lobes, that we don't miss anything. That is I was pointing the spleen, the liver, that is the gallbladder, a little bit sludge. He was fasted. And then I move a little caudally to see the stomach, a lot of gas, because my dog, he's a golden retriever, and he eats everything that he finds. So he has a little bit of gastritis and a lot of gas. And now I swipe the stomach, and I'm moving caudally to see all the intestines. You're going to see they're filled with gas. So again, this is my dog. He's like that. But I'm swiping everything just to make sure that I see all of the bowels that I can find in this side. There we have one. You can see all the gas that he has. And again, you can move the probe, swiping everything, also rotating and swiping everything you can find. You can follow all the bowels. And then what I'm going to do now is I'm going to show you where the left lobe of the pancreas should be. And you can see the spleen is going to be dorsally, then the stomach, then the liver, and right there is going to be the left lobe of the pancreas. Again, we weren't able to see it there, but that is where it should be. And then we turn them over, and again, marker cranially in the screen. If you put it caudally, just make sure that you switch it in screen. And I'm doing a swiping of all the intestines. Same thing here, intestines filled with gas. So it wasn't as easy as I expected. There I'm pointing out the ileocephalic junction, which is going to be a little cranially. And you can see in the probe is already a little bit subcostal, because sometimes with deep-chested dogs, you can find it a little bit subcostal. That is the duodenum. And again, swiping everything, duodenum. You can see the rectilinear course. So much gas. Then I'm going to show you the lymph nodes. So those are the jejunal lymph nodes. You can see the duodenum also there. Then I'm going to be moving a little dorsally. Hold on. There, I'm going to be moving dorsally and a little subcostal. Look how dorsal I am. I'm very, very dorsal. And you're going to see the kidney. You can't see it very well from the, there it is. You can see the kidney, very, very dorsal. Okay. So sometimes don't panic if you can't find it, because you have to go dorsal, or a lot of times even intercostal. And then to look for the adrenal gland, and as I was telling you, that is the kidney, and I'm going to do a little swipe medially, and that is where it pops out. That is what I did. So I went a little medial, and then it just comes out. The aorta, the vena cava, and right in the middle, you can see I did a little zoom for you to see. There it is. That is the right adrenal gland. I took another picture. There you are. Okay, then I'm going to move cranially. I'm going to try and go a little subcostal, but you can see that my dog is already breathing a little bit hard because probably it's not very comfortable. You can try and see the liver. You can see the diaphragm, and you can see the liver. I decrease the harmonics, and you can also increase the maps of gray, because that is going to help you to have a better image in a large breed dog. And again, I was swiping everything, as you can see, as I did with the right area. Sorry, with the left side. I'm swiping everything. I'm doing it a little bit faster than I would normally do, obviously, because we're just showing. But I would normally take a lot of pictures and everything. So, and then what I'm trying to do here is I'm going to show you the stomach, and I'm going to try and show you where the pyloric area should be. He has a lot of gas, so we're not going to be able to actually see it, but I'm going to tell you where the area is. This is going to happen with a lot of times. You're not going to see the pylorus because there's a lot of either food or gas. So there's the stomach. You can see subcostal, and I'm moving dorsally, so it's dorsocranial. You can see dorsally, and right there when I'm pointing, that is where the pylorus is. And I'm going to show you in the screen where it should be, because there it is. That is where it should be. I can see a little bit of the duodenum. I can see a little bit of the stomach, but I can't see the actual pylorus. But you can see it right there. And then last but not least, I'm going to show you the pancreas. So I look for the duodenum, and right dorsal to the duodenum, there it is, the pancreas. I can move a little bit caudal, but right there. Okay.